If you've got kids and you pay attention to health and wellness issues, you might have heard that experts are worried about the alarming rise in myopia among children. Myopia means that the eyes have difficulty focusing on faraway objects, but there are more serious implications than just needing a stronger pair of glasses. Once again, I'm talking with Paul Graham about a topic which he regularly discusses with patients in his clinic. Paul's a leading Gold Coast optometrist with over 30 years of experience. He's also the owner of Harmony Vision Care in Varsity Lakes. In this interview, we're going to be talking about myopia, the causes, and the available treatment strategies. But first, who am I? My name is Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps independent optometrists to grow their practice. So, Paul, good to see you again.
Likewise.
It's been such a long time. I mean, it's at least 10 minutes since we last talked.
Yes.
So full disclosure, we're doing back-to-back interviews today to catch up on some lost time due to some
Yeah.
certain weather events that happen.
Yes. Yes. The
Um,
old cyclone Alfred.
yeah. Anyway, so let's talk about myopia. So if my child has early stage myopia, what sort of symptoms would he or she be experiencing?
Sometimes none. I'm short-sighted myself, and mine was picked up by not being able to read an amusing bumper sticker on a car when the rest of the family could. For me, I didn't realize that I was sort of missing out on anything. And so in the early stages, that little bit of distance blur might not impact you too much in an obvious way. And if it creeps up on you, you kind of just get used to it. And certainly in the modern classroom, you talk to kids and they're using boards and screens a lot less now. And a lot of kids are at the front. And if they're at the front of the class, then they're at a distance where they can still see things. So yeah, so it can actually go unnoticed for the initial portion. Plus, I think it creeps up. So it doesn't just creep up. Sometimes the initial part of myopia occurs so quickly that you kind of get caught by surprise. And look, if and this is the reason why we say if there's a family history of myopia, sort of parents and siblings, then it's a good idea to get your kids checked recently to be trying to catch it as early as possible.
Yeah, I think anyone who wears prescription glasses has got like some kind of story such as yours. Like with me, I think I was about maybe 18, 17, 18 with some friends, driving and I took a wrong turn heading towards the Gold Coast. My friends are in the back saying, where are you going? And I just literally like I misread the sign because
Wow.
and it was at night as well. So, I think that maybe your night vision is the first to go. I'm not sure.
Yeah, and look, it was funny. I remember, the TVs when you and I were growing up. If you walked up close enough to them when they were off, you could actually see the little pixels on the screen. And so I always thought the TV screen was meant to look kind of pixelated and kind of fuzzy because it was made of pixels. And then after it got corrected, I went, no, I'm meant to be seeing it much more clearly and not realizing that you can actually see the leaves on the trees from a distance. Those kind of little things that you kind of just don't notice because it creeps up on you. But yeah, you look, so it can go unnoticed initially, but eventually the kids will start to squint or make errors with copying or just not being able to see what they're asking the kid next to them or what's on the board, or and like in your case, they're missing things in sport, or this just starts to become you know errors in performance and judgment and things like that.
I've got two kids, and one of them I think he's okay, but the other one I've noticed that I noticed that she was sitting closer and closer to the television, and I thought, okay, that this maybe that's a sign. This is a sign that we need to do something here.
Yeah, look, and some really young kids will do that because they want to get close to the screen and kind of tune out everything else, and they kind of get captured by whatever's on the screen. But if they're a primary school child that's becoming a new behaviour, then you certainly want to get that checked out. I just had a young fellow yesterday who we were concerned about his potential for becoming short-sighted because both parents were short-sighted. His sister's short-sighted, and one of the behaviours that prompted them to come back in was that he was walking up to the TV, which he hadn't done for a while at 8 years old. And sure enough, and he wasn't noticing any problems in the classroom. It was that behaviour of walking to the TV. Sure enough, we found that he was short-sighted. So
I have a link somewhere to um, there's a really interesting page online where you can it looks like a classroom. You can see like a perfect image of a classroom, and by adjusting the slider, you can see like how that classroom becomes blurred depending on how severe your myopia is. I'm not
yes,
sure if you're familiar with that one.
look, I've seen something like that, and I think we can kind of think of blur like that, but there is the ability to still understand what you're looking at, even though it might be blurry.
Mm,
Uh, and so sometimes the human brain's fairly incredible at adapting to these things. So, the amount of blur that you might get in that kind of simulator may not be sort of
mm,
properly match what someone's experience is, because it's a bit like, if you're reading letters on a chart, it might be difficult to identify those individual letters. But if we made those letters into a word, you could probably identify the word, even if a few of the letters were difficult to see. So
mm.
the brain's able to kind of fill in the gap and make really good predictions about things. And I think this is the other reason why sometimes people might not notice it being a problem, because they're not actually sort of making as many mistakes as we think they might.
And of course, I think this is one of the misunderstandings that goes along with myopia is that maybe some people they hear about myopia and they think about, okay, well, yeah, sure, you have problems like seeing things at a distance, but just get a pair of specs, and you're good to go. That's problem solved, right? But there's actually like longer term implications to this.
Absolutely.
Do you want to talk about that?
Yeah, well, and part of the problem with just getting a pair of glasses is it doesn't stop it from getting worse. And so you've got that sort of increasing myopia that you just need to deal with, which is inconvenience on its own. But, a lot of the research is now indicating that the more short sighted you are, the higher the risk you have of developing other eye disease and eye problems as an adult. And, glaucoma, which is one where the pressure goes up in the eye. The problem with glaucoma is that it's a sneaky disease. You don't get a lot of symptoms from it until it's upon you. And often it's picked up through routine testing of pressures and other aspects of your vision. You've got a higher risk of getting a thing called a retinal detachment. So that's where the retina pulls away from the back of the eye effectively. As the eyeball grows, then the cornea, the retina itself gets stretched. And so you can get tears and breaks in that, and then that can actually pull away. That can result in sight loss and sight distortion. You've also got issues around developing a higher incidence of macular degeneration, particularly in very, very high amounts of myopia. So part of the overall global goal is that we want to reduce the number of people who get to that point of having a very high risk of these extra problems.
And some of those things, like especially macular degeneration, they're irreversible, aren't they? So once you've got a severe situation like that, there's not much you can do.
Yeah, and the type of macular problem you get with myopia may well be different to the regular age-related macular issues. Absolutely.
Okay. All right. So let's say, like in my case, I've noticed that my kid likes to sit closer and closer to the TV, and I bring her into your clinic there. What's your process like? What questions do you ask? What tests do you run?
Yeah, so we do a case history. So we might ask them about, how easy are they seeing things in the classroom, distance and near, what sort of devices they use, how long they use them, what sort of activities that do they participate in that takes them outside. So what sort of sport and other things. We want to know parental history, because your chances of developing myopia increased for every other direct family member who is short-sighted. So, you know, it's more risk with two parents than one parent, as an example. Um, that's probably the core questions. We're still short-sighted people are notorious at having poor near visual skills, even though they don't have visual symptoms at near distances as much as other people do. And so we need to sort of be aware of generalized visual dysfunction in addition to them maybe starting to have problems with their distance vision.
Hmm. Okay. And so you'd still do the typical eye chart tests, or
Yeah, and that's probably the most obvious one that picks up the problem where they're no longer able to see 20/20 or 6/6 on the chart, and then that would then match up to their prescription. And so we do a prescription check and find that they need some minus lenses to restore good distance vision. And one of the mainstays of myopia control now is also looking at axial length. So axial length is the distance between the front of the eye and the back of the eye. So effectively, if we get the old model again, so from the cornea to the back of the eye here is the axial length. And so in myopia development, this eyeball grows longer. And there's a fairly good correlation between increasing levels of myopia degree and your axial length. So I could normally point to it. It normally sits about there, but someone in the practice has seen some myopic kids today and has taken the machine that we use to measure axial length. So that's a very important part of, diagnosing and then managing myopia afterwards.
That does require special equipment then to measure that axial length.
Yeah, look, you don't need it to find myopia, because just distance blur and blur that's corrected by a minus lens is a fairly basic definition. But yes, if you're serious about managing myopia, ideally you are measuring axial length as one of the primary measurements that you use for treatment effectiveness.
And what is the youngest age like to really start testing for myopia? Like if I've got a child who's like 3 or 4, is that too soon to really be concerned about this?
So getting an axial length measurement at that age is difficult, but we would recommend getting a test around 6 to 9 months old, and that's just more for general visual development. Same thing around 3 years old. Now, the classic thinking is that at the 3-year-old, we're really looking at things more like eye turns and lazy eyes and those sorts of things. But so certainly by the time you get to preschool, sort of 4 or 5 years old, you definitely want to be getting some measurements, particularly if there's a family history. There's some suggestion that if you've got, most kids are a little bit long-sighted or hyperopic, and if you've got a lower level of that hyperopia compared to the normal, that may be considered a predictive factor that you might be heading towards myopia. And so it's good to have that as a baseline to kind of get a sense of, well, how much has it changed? I even saw my own daughter change within 9 months. She was reasonably hyperopic, and then 9 months later she wasn't. So, these things can change quite rapidly. So having some sort of baseline measurements is particularly good.
And you touched on some of the root causes here of myopia, which is environmental, but also genetics plays a role as well, doesn't it?
Absolutely, a combination of the two. And so there are, where you look into sort of genetics, is that you've got the family background. So, the classic one, 20 years ago, if we had a child who was developing myopia sitting in our chair, you were almost guaranteed that the parents were myopic as well. Fast forward to nowadays, I've got lots of parents who are coming in where there is no history of myopia, yet the child's becoming myopic. And so you kind of go, it is absolutely a mixture of that inheritance, but also environmental factors. And, we've discussed in the past, we know that there is a higher incidence of myopia in East Asian cultures, is it environmental because of lifestyle, cultural differences, large populations built in built environments, or is it genetic? But pretty much across cultures, there's been an increase in the prevalence of myopia over generations. So absolutely a combination of the two.
Yeah, I don't remember the exact statistic, but I think that they think that, within the next 10, 20 years, maybe half the population of the world is going to have myopia.
Yeah, 2050 was the kind of marker that 50% will be short-sighted. Yeah. And I think Australia recently has been sitting around that sort of 27-30%, which is where America was in the 70s. They're now at the sort of over 50%. So it's certainly sort of changed over time. And outdoor, it's interesting when you talk about, look at relationships in research, that we often talk about correlations and relationships and associations, because it's very difficult to talk about cause. It needs a very, very high level of scientific proof for a researcher to be able to kind of state that with confidence that something's the cause. And myopia is one of those areas in vision care where they're pretty confident in saying that spending more time outdoors delays short sight, and that the lack of outdoor activity is a cause of early short-sightedness development or myopia development.
And outdoor time, that's you were speaking about that, but when it comes to UV, like UV light, does that have any in itself? Does that have any like beneficial effects for myopia, like
It's a great
reducing myopia?
question. Yeah, and that's a great question. What is the benefit of spending time outdoors? Is it the overall volume of light that's available? Is it the UV that's protective in some way? Is it I saw one paper years ago that I think makes a lot of sense, that when you're in an indoor environment, you have a lot of light reaching you from very close distances, walls and roof, that you don't get exposed to outside. If your brain's affected, your retina is effectively a little bit of brain tissue, that it's averaging where that light is coming from across the day as a potential trigger for short-sightedness. And so you've got all these close distances, and so maybe it's an adaptation to that. And that the benefit of outdoor activity is that you have this more natural light coming from further away. So lots of theories we still don't know, and that's that tension as a clinician to say get outdoors but still be sun safe, and you're kind of going, well, is the UV increase part of the magic? We just don't know. It's a challenge.
Interesting. Well, if you're enjoying this conversation and you're getting value out of it, don't forget to hit the like button if you're on YouTube. It really helps us out, and also the subscribe button as well if you want to be notified when Paul releases more high value videos such as this one. So, Paul, all right, so we've talked about the symptoms and the causes of myopia. Now let's talk about treatments, because I think there is quite a spectrum of options which parents have for their kids if they are diagnosed with myopia. So can you tell us, like, what are some of the common strategies that you use in your practice?
Yeah. So look, behavior counseling is a broad term where we kind of go, well, we know that intense near work coupled with not enough time outdoors may well be part of the trigger of early myopia development. So regardless of your journey, whether you're not yet short-sighted or already short-sighted, then maintaining some good visual habits of taking plenty of breaks with near work, getting up and moving around, preferably outdoors, spending as much time as you can outside, at least 90 minutes a day outdoors, and trying to keep your device use under 2 hours per day is kind of a general bit of advice, and certainly a strong one for people who are not yet at that myopia development stage. I think we can all confidently now say that just prescribing a distance lens is probably not really an appropriate thing to do anymore in someone who's highly likely to progress. And so, the younger you are, the more parental history that you have, and depending on your cultural background, these are all increase your risk factors for progression. So if you sit in that sort of medium to high risk of progression, then just prescribing glasses to restore distance vision and doing nothing else is probably no longer appropriate, particularly when we've got so much choice now especially in Australia, where a lot of the leading research in myopia for a long time has come from Australia. So I'm very fortunate in that regard, and our close proximity to Asia as well means that we have access to a lot of myopia control products, and a lot of them are optical devices. So we've got really started out, one of the leading ones that probably has one of the most bits of literature and research around it is orthokeratology, which is the lenses that you put on your eye overnight. And I've worn them as an adult to correct my myopia. It wasn't for controlling my myopia. It was just certainly just a method of restoring distance vision. And so it started out as an adult treatment to have something as an alternative to contact lenses, laser surgery, because you could wear a lens at night, take it out when you wake up. Because it's a stiff lens, it's temporarily reshaped the cornea on the front of the eye, and you get this benefit of seeing clearly. And the accidental discovery that came from that is when you fit kids and teenagers with them, their progression in their myopia appeared to slow, and the research has certainly backed that up now, that that's a primary strategy for slowing progression. So you get to see clearly without wearing glasses, and also you slow the development of your myopia. You can also do that through a contact lens that you wear during the day. Now, it's not reshaping your eye, but it's creating a certain type of optical defocus that they have shown slows myopia progression. So you've got a number of different soft contact lenses. You can call them dual focus or multifocal. There's lots of different names. The main idea is that they're not a single vision sight correcting only lens. And so we've got those available, and they've been around not quite as long as Ortho-K, but certainly getting fairly close. And things like the MySight lens, there's Natural View, there's the Seed lens from Japan, there's the Milo, I think, from Spain. So there's a number of different lenses available.
So they're all daily disposable, are they? So like the soft
Those are all
contacts
daily
you just throw
disposable.
away. Yeah.
The Milo lens might be a monthly. We can use some monthly disposables where if someone's got astigmatism, that is too much to be corrected by a normal daily myopia control lens. We've got those sorts of things that we can order. And then you've got spectacle lenses, and there's a number of spectacle lenses that come on the market over the last couple of years. I can think of at least 5 or 6 now available in my practice that we are able to choose from based on the individual needs of the patient. Actually, it might be closer to 8 now I think about it. So we've got plenty of choices, and they all have varying degrees of ability to slow progression on average.
Right. Yeah. Just on that point, I'd I do they all use like the same sort of defocusing approach to slowing myopia? And if so, like, what is the difference between the lenses? Like what would prompt you to say, okay, I think you should choose MyoSmart versus Stellest or something else?
Yeah, look, some of it might be that you might choose it based on the population that lens was studied on. So if you're dealing with someone where a lot of the data from that particular lens came from Asian countries, and you have someone who has an Asian background, then East Asian background, then you might choose that lens versus someone who is Caucasian and use a lens where the data comes from sort of more Caucasian studies. That can sometimes come into it. There are some people with myopia who also have different forms of binocular visual dysfunction, and there may be varying degrees of weighing up the tension between making sure that you're paying attention to other aspects of how they're functioning visually and the myopia. And so you might be leaning into a lens that maybe might not be as effective at controlling the myopia, but provides quality of life in other ways. So there are some of the other things that you need to balance, and that's probably something that's sometimes overlooked. Is everyone gets caught up on the myopia aspect and forgets the person that's got 2 eyes and has to have good function of the 2 eyes working together in terms of binocular function and focusing. They're probably the primary things. You might adjust it based on the risk of progressing more rapidly because they're younger versus older. So there's a number of different things that you might use to consider for that individual patient that's sort of sitting there.
Okay. And are there therapies? Are there exercises that you can do to slow down the myopia?
Look, the research into doing vision therapy or exercises is just for myopia specifically is not there. It would be an interesting thing to look at, because there appears to be influences in certain types of binocular dysfunction into myopia progression, higher versus lower. And it would be great to have those studies, but trying to get funding for that when the approach to myopia at the moment is a global approach at trying to reduce the overall levels. So they're looking at sort of what are the simpler strategies. So it tends to be sort of fairly lens based. If someone's got symptoms from binocular visual dysfunction, then certainly vision therapy has got a place there, but we don't go into it as something where you're promising any sort of control over myopia. I've certainly seen the odd case where we've been able to reduce the amount of myopia a little bit with the vision therapy, but it's not something that I would recommend as a primary strategy. Really getting into using lenses as our primary strategy at this stage.
And just in case anyone's thinking about this, so LASIK and like laser surgery for vision correction. I mean, I think that's something that they probably don't do on people whose eyes are still developing anyway.
Certainly in this country. So certainly in Australia, it's you have to be 20 and you have to be stable.
Yeah.
So, and if we take an example of my Ortho-K patient, so we opened the practice over 20 years ago with two things in mind. We wanted to provide Ortho-K and myopia control services to the Gold Coast, and we wanted to have a very professional, dedicated setup for doing vision therapy. And so I've got people who have been wearing Ortho-K for quite some time. And so we have that discussion as they are starting to get to an age where they might want to consider doing something other than lenses, glasses, or Ortho-K. And the discussion I have is, well, we need to at least wait until you're in your 20s because the surgeons prefer that. Part of that is traditionally your progression slows. I think the old data used to be about 1 in 10 people in their early 20s still progress, and about 1 in 20, so about 5% still progress when they're in their mid-20s. I think with modern life, the data's potentially more like 1 in 3 still progress. So we need to be really sort of cautious around that. So my approach with an Ortho-K wearer is to say, okay, let's get through your studies, let's get through high school and uni, stop wearing your Ortho-K for 12 months. That does two things. You move into regular contact lens wear or regular spectacle wear. It allows plenty of time for your eye shape to return to its baseline. And because that's the part that they're going to laser is the cornea. So we want to make sure that shape has returned to its baseline shape. And we also want to demonstrate that you're not going to progress when you don't have something there trying to stop the progression, to prove that you are now well and truly stable. So that's where laser surgery sort of fits in this whole scheme of things. You want to be someone who's definitely stable.
So just to be clear, so laser surgery, it might fix the refractive problem, but it doesn't do anything to stop that eyeball elongate,
Correct.
does it?
Yeah, and I haven't seen strong enough evidence, and the practicality is that no one in this country is going to do LASIK on someone who's young anyway. So it's a big point either way. But yes, it's only about restoring. It's just another way of restoring clarity in the distance again.
Yeah. And I've heard that like with all of these types of myopia control strategies, the earlier you start, the better the results. So like you're gonna maybe get more, um, you've got more hope of success if you start with a child who's maybe 7 or 8 than one who's 15, 16. Is that right?
So it's more important to really be careful around getting in early. So this is part of the conversation you have with parents that, a late starter can still progress. So we still need to manage the progression. So there's still value in managing the progression at any age. The concern about the early starters is that they've got a lot longer for the progression to be in place. So there's two things that happens when you're young, that when you do progress in your myopia, the changes over time are a lot more rapid, and the amount of time that you've got to develop myopia is longer. So you've got two things that kind of make it a big concern. And part of this is based on, in an ideal world where we'd be able to stop myopia in its tracks. The reality is we just slow it down. And we're trying to avoid the average level of short-sightedness from hitting about -550 and higher. And so, the younger you start, the quicker you go, the longer you have for, eventually reaching those kind of levels.
But that slowdown could be, I mean, the cumulative effect of it, it's not nothing, is it? Like, I think with some of the studies, they talk about reducing that progression by 50 or 60%. Is that right?
Yeah. So your Ortho-K, your higher doses of Atropine, your contact lens where you're sitting in that. So I always say it's around that 50 to 70% kind of level. And the glasses on paper are saying similar sort of levels now. We've just had a little less time clinically to see if what we're getting in the clinic is matching kind of the data. And there are other types of lenses where the progression control is probably around that 30 to 40%. but they're all contributing in a way of actually slowing it down compared to just doing nothing or wearing a regular pair of glasses.
Right. And we'll just to paint the full picture here,
Mm.
we should probably talk about atropine eye drops.
Yeah, so
That's been something that's been around for a while, hasn't it, as a strategy? But I think that some practitioners like yourself have sort of like a mixture of views about that.
yeah. So look, I'm not against it. We tend to use it in a situation where the other strategies aren't working well enough for a particular patient, or for some reason they're just not available. And the thing with atropine is that the higher doses certainly slow down the progression more, but you get a high dropout rate because the side effects from the drops start to make the treatment sort of something that someone doesn't tolerate. And so once you lower the dosage down to a more tolerable level, you are getting similar sort of outcomes from atropine that you get from spectacle lenses, contact lens wear, and Ortho-K. So you kind of go, well, we're going to have to correct your sight anyway. Why not use the optical devices first? Because you're going to have to correct your sight anyway. And that way you don't have this additional drop that you need to kind of be doing at the sort of same time. And there's research going into how effective they are as an adjunct therapy. So if you've got someone in Ortho-K or myopia control contact lenses and their progression is still more than you would like, is there benefit in using a atropine as an additional one? But that the research is still equivocal on that one. And there will be some people who hear about atropine and that's the approach they want to take, and I will refer if that's the way that they would go with it. Like I said, the vast majority do well in our, let's call it, regular myopia control strategies.
So what I'm hearing you say is that if your child has an obvious like refractive problem, they're struggling to focus on things, then eye drops maybe are going to slow down myopia, but they're not going to help them see better.
That's right.
They probably need glasses or contact lenses anyway.
Exactly. They're still, they're going to have to wear. And there is an argument that not wearing glasses or wearing a weaker prescription may actually increase the progression. People sort of talk about a lot. My looking at the research is I don't know how much impact an undercorrection or no correction actually has on myopia, other than it's not a strategy you choose to use. It's not effective. I don't think it's necessarily better or worse than full correction. I just don't think that full correction or no correction works at trying to slow down myopia at all. So, but the reality is, yes, if you're becoming myopic, there's just the quality of life issue of not being able to see. And so, you need to see, you need to have glasses. And then if your option is atropine to slow it down, then so be it. But you still need to be wearing an optical device in order to restore distance vision again.
And we should probably do some myth busting here, and that is that like wearing glasses isn't going to make your eyes weaker, is it? Like just regular glasses.
Yeah, that's right. And I think let's sort of pull apart where that comes from. And there are two conditions that progress regardless of whether you're wearing glasses or not. And one of them is myopia. So correcting your myopia is not the cause of the progression. The cause of the progression is that's the nature of myopia, and perhaps your visual habits during the day. And the other one is the presbyopia. It's the age-related loss of flexibility in your lens, so you can't see it as well at near as you used to. And it's a progressive condition. It's like chasing your grey hairs and your wrinkles. It keeps getting worse. The glasses, your first pair of reading glasses were prescribed because you were having problems first. It didn't happen the other way around. We just can't slow down presbyopia, unfortunately. So it's just natural for your reading prescription to get stronger every couple of years.
Okay, so I brought my daughter in. We've agreed that she's got myopia. Maybe we've prescribed some defocus lens glasses for her, whatever it may be. So how often do you need to, or how often would you like to see patients if they do have signs of myopia? Like, what's a normal program for you of follow-ups?
Yeah, look, if we've got someone who's definitely now short-sighted, then we need to get a handle on what the progression rate is like. So part of the discussion is looking at, what's your risk of progression. I like to put the power of the decision in the patient's hands. And so on the odd occasion, you will get someone who wants to wait for a little bit longer before we employ any treatment. And regardless of whether they go for treatment or not, my first strategy is, well, we need to be measuring someone every 3 months initially to get a handle on what the progression's like. So either if you're not getting treatment, how quickly is this traveling? If you are getting treatment, how quickly is this traveling? Is our treatment, how effective is it? Once we get a handle that the progression is in an acceptable range, we might move to 6 monthly. And then if it's really showing good consistency and stability, then we might go every sort of 12 months. And certainly if you're a contact lens wearer or Ortho-K wearer, if it's not for myopia control, it's just something you're wearing as your method of sight correction on a daily basis, then the norm is to see you every 12 months anyway. So the short answer is it'll range between 3 monthly and 12 monthly, depending on the individual sort of situation.
Right. Okay. Well, it's been excellent, Paul. So thanks for sharing that information with us. So if people want to get in touch with you there at Harmony Vision Care in Varsity Lakes, what should they do?
So harmonyvisioncare.com.au. So we've got some great resources there, the ability to ask questions and also book an appointment through our online booking system. If you want to ring and chat to our team first, it's 0755205900, which again, you can find that number on the website as well.
Okay, and don't forget to follow Paul's Facebook business page and also his Instagram account. Let's not forget that one. So he's regularly posting helpful content and short videos that cover topics like this one today. All right, well, I think let's wrap up there, Paul. So any last words of wisdom?
No, it's just a matter of getting regular checks done. The 9 months, 3 years preschool, and then a couple of times during primary school. So just being on the front foot, particularly if you are, as a parent, are short-sighted, or one of your other kids has already become short-sighted. Just regular checks are a good way of picking these things up early.
Okay then. All right, Paul. Well, once again, thanks very much, and until next time, bye for now, everyone.
Thanks, mate.